Dr. Aaron Singh describing the valve-sparing reimplantation David operation for aortic root aneurysm with aortic regurgitation. 53-year-old male presented with shortness of breath, decreased exercise tolerance, New York Heart Association Class 3. Blood pressure 140/70, grade 3 diastolic murmur over the precardium. Underwent transesophageal echocardiogram, mid-esophageal long axis sewed, severe aortic regurgitation, short axis again shows central severe aortic regurgitation. On this view of on echocardiogram, it showed the aneurysm of the sinuses of Valsalva and dilatation of the aortic annulus. Transgastric view shows the eccentric associated significant flow convergence consistent with the severe aortic regurgitation. CAT scan shows a pure separate ascending aorta, normal arch, ascending aorta measure 5.2 centimeter. Patient went to surgery, chest was open, placed on cardiopulmonary bypass, left ventricle decompressed, heart was cooled to 32 degree, aorta was cross-clamped, cardiopulmonary ran, aorta was transected transversely, just distal to sinotubular junction. The renal portion of the disease, sinus of Valsalva was removed. The aortic root was freed all around, freed from the right ventricle, right atrium, left atrium. The graft sizing technique is based on the principle the height of the commissure measured from the base of the interleaflet triangle to the top of the commissure equal to the external diameter of sinotubular junction. Line was drawn at the base of the non-coronary and left cusp, and the height was measured at the top of the commissure. It was 3 centimeters. Because of restriction of the anterior lead between the right and the non-coronary cusp, height of the commissure was again measured. This was shorter than the commissure between the left and the non-coronary cusp. In two trichronon prejudice suture was used, subannular suture. First suture was placed at the base deep into below the non-coronary cusp, and also the second one was underneath the left coronary cusp. The height of the commissure between left and non-coronary cusp corresponds with the size of the graft, in this case 30 millimeter. Valsalva graft was picked. It has 3 markings, which corresponds with 3 commissure of native aorta. The collar, approximately the collar of the graft was cut. Additional opening was made to accommodate the aortic root when the graft was lower because of the height was shorter between the right and the non-coronary cusp. Pleasure sutures were placed all around the subannulary. First sutures were placed follow horizontally and then follow the line of the aortic cusp attachment. Subannular sutures were passed through the Valsalva graft at the collar. The graft was telescoped with the commissure inside. And a Hagar dilator was placed and sutures were tied. Sutures were cut. The Hagar was used so the valve, aortic valve would be not narrowed or distorted. Hagar dilator was removed. You can see that the remaining portion of the aortic wall was sutured to the graft using a 4-operating running suture. The sutures were used from inside out to avoid any destruction or injury to the native aortic valve. Here is a valve, looks like a Mercedes sign. The commissure were fixed to the sinotubular junction of the graft. The aortic leaflet, you can see it. It was prolapsing, very thin, frail, and was very prolapsing as well as at the hinge of the commissure. A resuspension technique was carried out using 7 suture. The initial suture started right at the commissure, ran halfway, over and over, to and forth, and then eventually coming back and tying to the commissure. Once this was done, you can see this reinforced the leaflet as well as shortened it. This will give another durability of the leaflet. The valve was checked compared to the reference valve leaflet. You can see the left leaflet was prolapsing. It was below, the height was lower than the other, and this is being plicated using 7/0 Gore-Tex sutures. The left cusp was shortened by a couple of millimeter. Now it was tested and checked again. Now the height of the all three leaflet looks pretty reasonable, the same height, and the redundant portion of the plication was over sewn, and during the entire procedure you can see it. The cardioplegia was carried out through continuous cardioplegia through polystyrene cannula into right and the left coronary orifice. Suture was tied. The repair of the left cusp of the coronary was completed. Now all the three leaflet looks like a similar height. Once we brought together, saline test was carried out. There was no leak, and you can see all three valve leaflet come very nicely. Nice Mercedes sign. The hole was made for the left coronary anastomosis in the graft using a cautery, and left coronary was anastomosed 6-proline on a pericardial gusset. This anastomosis was checked again. Now the distal end of the graft was anastomosed to the proximal aorta using 4-proline. If the quality of the aorta is not good, then we will use a Teflon felt during the anastomosis. Cardioplegia ran into the aortic root. The graft was distended. Opening was made in the anterior to the graft for anastomosis of the right coronary artery. We have to be careful here not to damage the aortic leaflet. Usually the opening is made very high. 6-proline was used to anastomose the right coronary. Sutures were placed very close to the coronary ostia to avoid subsequent or future aneurysmal formation and also possible distortion of the coronary arteries. Air was evacuated. Cardioplegia ran again. Aortic cross clamp was removed. The diagram represents the completion of the operation. Coronary anastomosis, post-op esophageal transesophageal echocardiogram showed the valve leaflets are moving nicely. There was thickening of the leaflet because of the suture and plication. One could see very nicely also there was no aortic regurgitation on long axis. Transgastric view shows a diastolic flow in a mitral valve. but there's no aortic regurgitation. The coaptation height is 0.9 centimeter, which is a pretty good size, and the aortic valve area is about 2 centimeter with a mean gradient of 13 millimeter across the valve. Again, on 3D, coaptation height was 9 millimeter. CAT scan showed a normal aortic root with normal coronary anastomosis. Over the last 20 years, we have performed 163 patients. The mean age was 46 years. The men's were 71%, Marfan was 26%, bicuspid valve was 21%, aortic dissection 16 patients 10%, and trauma was 2%. Out of 163 patients, reimplantation procedure was carried out 112 patients, 69%. Remodeling procedure was carried on 51 patients, 31%. Aortic cross-clamp time was 131 minutes, plus or minus of 24 minutes. 45% of the patient require repair of one or more valve leaflet. 6% of the patient require reinforcement of the leaflet with a Gore-Tex suture. 6% of the patient require associated procedure, coronary artery bypass surgery, aortic arch replacement, mitral valve repair. 4 patients, 2%, require repair of the leaflet using a core matrix. There were 2 deaths out of 163 patients, mortality of 1.2%. 1 death was from CVA, other was from dissection of the coronary artery. There were 5 late deaths, 3% late death. Survival at 10 years was 90%. Freedom from moderate to severe AI was 90%. Reoperation replacement of valve was 5 patients. 3%, 4 out of 5 patients had remodeling procedure done. The David procedure with valve repair for aortic root aneurysm with AI is a durable procedure and should be considered in a patient with when valve is repairable. Thank you.